Yes, sir. 3, 2, 1, start.
A very good morning to all of you. Once again, welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, in our teaching class, we have an interesting topic on extracorporeal shockwave lithotripsy. We know extracorporeal shockwave started in 1980, and then probably with the development of URSL, IRS, CCNL, it a backseat, but still we know ESWL.
Sir, your audio video is gone. नहीं ये चल रहा है सर नहीं कर Sir, your net connection is gone. Good morning, sir. Sir, आप उधर सर नो मिट्टी बस super.
Sanyam, can you hear me? Okay.
Sir. So your voice is coming interrupted. बाकी सबका आ रहा है सर, आपका आवाज नहीं आ रहा है. Yes, sir.
Can you hear me now?
Yes, sir. Yes, sir.
Sanyam, go ahead with your presentation, please.
Am I audible, sir?
Yes, yes. Go ahead. Share your presentation.
My screen is visible?
Yes, visible. Go ahead.
Very good morning to one and all. The topic for today's presentation is extracorporeal shockwave lithotripsy, indications and technique, presented by myself, Dr. Sanyam Nandwani, and moderated by Dr. Ajayraj, sir. We start today's presentation with this photograph of ear-shaped limestone cave built during the times of ancient Greeks, known as Ear of Dionysius, in the city of Syracuse in the island of Sicily in Italy. They say that the Greek tyrant Dionysius of Syracuse used the focusing system of sound waves to overhear the plans of political descendants kept as captives, and also to hear the amplified screams. Why this is all important? Because this is how, since how long or old, since the time of ancient Greeks, we know that the waves can be focused, which is the backbone concept of today's ESWL. The topic will be discussed under the following headings. Moving on to the introduction, extracorporeal, which means from outside the body. These are weak, non-intrusive waves that are generated externally and transmitted through body and focused onto a stone. The shockwaves are surfaces that divide materials ahead and are not affected by disturbances present behind. They propagate in a non-linear fashion. In 1966, from the idea of raindrops destroying the airplane not only externally at the point of impact, but also internally by creation of shockwaves, led to start of research by Dornier on the effect of shock waves on biological tissues. In 1972, after preliminary studies, an agreement was reached between Dornier Medical Systems and Egbert Schmidt, who was director of urology at University of Munich, for development of lithotripters. In 1980, after several prototypes by the name of TM1, TM2, and TM4, first human model or HM1 lithotripter was made, which treated the first patient by lithotripsy. HM3 was the first commercial lithotripter which used water bath, and 1984 ESWL was approved by FDA. The advantages of ESWL being it is a non-invasive and safe procedure. Procedure can be done on a daycare basis, can be used for all age groups, and anesthetic complications can be avoided. Disadvantages being multiple sittings being required, not suitable for all stones, especially hard stones, and associated with certain complications. AUA stone guidelines have classified ESWL as a potential first-line treatment for ureteral and renal stones less than 2 centimeters. These are the guidelines for a non-lower pole renal calculus. We can see that in a stone of less than 1 centimeter, SWL being the first treatment option, and Hounsfield units and the skin to stone distance being major determinants of determining treatment. In case of a lower pole treatment, a lower pole calculus, another factor is added by the name of favorable anatomy, which we will discuss later. In case of ureteral calculus, stones less than 10 mm can be treated by ESWL or URS. Contraindications include acute UTI or urosepsis, uncorrected bleeding disorders or coagulopathies, pregnancy, uncorrected obstruction distal to the stone, abdominal aortic aneurysm, renal artery calcification, and a non-functioning kidney. Relative contraindications include altered body habitus such as morbid obesity or orthopedic or spinal deformities, stone sizes more than 2 centimeters, stones present in calyceal diverticula with narrow infundulum, or renal ectopy or malformation. ESWL is usually done by giving approximately 2,500 to 3,000 shock waves. Larger or harder stones may require a retreatment gap of 10 days, and crushed stones are usually passed within a period of 3 weeks. Lithotripsy machines usually have 4 basic components: a shock wave generator, a focusing system, a coupling mechanism, or an image or localizing unit. The shock wave generators can be electrohydraulic, electromagnetic, or piezoelectric. Electrohydraulic generators were the first generation used in first generation lithotripsers. They are also known as spark gap generators. The shock waves are generated by underwater spark, and which leads to expanding of vapor bubble and which collapses rapidly, producing a high energy pressure wave at focus 1, which is the electrode. The shock waves are reflected by ellipsoid reflectors to F2 or the focus 2, which happens to be the stone. They consist of a water bath and a metal gantry chair. They have disadvantages of substantial pressure fluctuations from shock to shock, a shorter electrode half-life, and 1 millimeter displacement at focus 1 can lead to up to 1 centimeter shift at focus 2 or the stone. Electromagnetic generators are generated by an electromagnetic coil which moves a static membrane. Membrane vibration produces shock waves. The acoustic lens system reflects and focuses the flat plane shock wave. The resulting shock wave is constant, and the energy is focused to a smaller focal point, which is F2, the stone, with a higher peak energy. Cylindrical waves can also be produced, which are reflected by parabolic reflectors. Electromagnetic generators have advantages of left wear out and less servicing. There's less pain as energy is focused onto a larger surface area. They're more comfortable, more controllable, and reproducible. Disadvantages being increased rate of subcapsular hematoma formation due to high energy density at focus 2. Piezoelectric generators, in piezoelectric generators, the shock waves are generated by mechanical deformation of a piezoceramic crystal. These crystals are lined along spherical dish, which allows focusing. Advantages being a focusing accuracy, long service life, and anesthetic-free treatment. Disadvantages being their power is insufficient to break stone effectively because limited total energy is delivered to the focus, resulting in poor stone combination. Lithotripter designs can be modular, in which all the components, such as the shockwave source, imaging components, and treatment table, are separate modules that have to be connected. It can be integrated into one standalone system, or it can be a hybrid as mounted on a combined console. Coupling mechanism, it is usually needed to minimize the dissipation of energy of shock waves as it traverses the skin surface. The usual medium is water. In the first generation, patient was placed in water bath, which was used as a coupling mechanism. In second and third generations, small water-filled drums or cushion with silicone membrane were used to provide air-free contact to patient skin. Currently, ultrasound jelly, silicone oil, petroleum jelly, or shaving can be done. Stone localization can be done by fluoroscopy, ultrasound, or combination of both. Fluoroscopy has the advantages that it is familiar to most of the urologists. It has the ability to visualize radiopaque calculi, and iodinated contrast agents can be used to locate radiolucent stones and to display the anatomical details. Fluoroscopy has disadvantages that there's exposure of radiation to the staff and the patient, there's high maintenance of the equipment, and we cannot visualize the radiolucent stones without use of contrast agents. Ultrasonography, it has advantages of being non-expensive. It can be preferred in treatment of children and when there's concern about dose of ionizing radiation. In addition, ultrasonography can localize radiopaque or radiolucent calculi. Disadvantages being it requires a highly trained operator, and it is almost impossible to view a stone in areas such as middle third of ureter or when there's an indwelling ureteral catheter. Both can also be combined. Mechanism of stone fragmentation includes fall fracture, squeezing and splitting, shear stress, superfocusing, cavitation, and dynamic fatigue. Spall fracture, once the shock wave enters a stone, it will be reflected at the sites of impedance mismatch, such as location of distal surface of stone at with the interface at the fluid levels. As the shock wave is reflected, it is inverted in phase to a tensile or a negative wave. Then when the tensile wave exceeds the tensile strength of the stone, it results in induction of microcracks, which eventually coalesce, resulting in fragmentation, which is known as spallation. Squeeze splitting, the shock wave advances faster through the stone than in the fluid outside the stone. The shock wave that propagates in the fluid outside the stone produces a circumferential force on the stone, resulting in a tensile strength in the stone, which is maximum at the proximal and distal ends of the stone. Shear stress, the shock wave propagates to the stone and will result in regions of high shear stress inside the stone. Superfocusing, the shock wave that is reflected at the distal surface of the stone can be focused either by refraction or by diffraction from the corners of the stone to create areas of high stress in the interior of the stone. Cavitation is formation and subsequent collapse of bubbles. During the negative pressure, the pressure inside the bubble falls below the vapor pressure of the fluid, and the bubble fills with vapor and grows rapidly, and then collapses violently, giving rise to high pressures and temperatures. Dynamic fatigue, the damage induced by ESWL accumulates during the course of the treatment, leading to eventual destruction of the stone. This is a flowchart showing how actually the ESWL works. First, the shock wave generator generates waves which travel through the water. The body-water interface has similar impedance, so there is no energy dissipation. The energy surface of stone, when it is reached, there's sudden change of impedance, which results in release of compressive energy. At the exit surface of stone, there's another impedance change, which results in a shock wave, which is released as a blast. Repeated cycles cause the stone to disintegrate. Patient preparation is done by taking a proper history and physical examination. Lab studies are done, which include CBC, coagulation profile, urine analysis, and culture sensitivity. Imaging studies can be done in the form of ultrasonography, X-ray KUBs, and CT KUB. Antibiotic prophylaxis is given in cases of indwelling devices or when there's bacteriuria suspected. To optimize shockwave lithotripsy, proper patient selection should be done in terms of stone size, composition of stones, skin to stone distance, stone location, and Hounsfield units of stones. Stone characteristics, most calcium oxalate monohydrate stones are most resistant. When the stone density of stone is more than 950, it results in it shows poor results on ESWL. Patient factors include a skin to stone distance of less than 10 centimeters usually show a better response. A BMI of more than 30 has a poor response. In case of lower pore stones, various characteristics are used, such as infundibular length of less than 3 centimeters, infundibular width of more than 5 centimeters, and infundibular pelvic angle of more than 70 centimeters. Anatomic variations such as fused kidneys, malrotation show poor results on ESWL. Device-specific factors such as acoustic output and focal volume. A wider focal width increases the likelihood of stone breakage. Optimal coupling should be done, as it is seen that 2% of the coupling area loss diminishes the stone breakage by 20 to 40%. Water-soluble lubricating jellies are required. The number of shock administrators should always be kept in check. The rate of administration and the power of voltage that is used should always be kept in check. Anesthesia and analgesia requirement. SWL can be performed under anesthesia or analgesia. The objective is to pursue complete lithotripsy under optimal conditions, possibly within one treatment session. And this objective can be reached by keeping the patients relaxed and painless for the entire duration of treatment. The benefits of anesthesia being that the patient movements are less, and there's more consistent breathing movements, which results in shock waves being targeted on the particular target. There's higher maximum energy levels can be reached. Entire therapy can be done probably in one session. For a successful ESWL, 3 prerequisites are required: a functioning kidneys, unobstructed distal passage, and higher triple-D scores, which include SSD or skin to stone distance, stone density, or ellipsoid volume. For improving hit rate, patient should be properly positioned. For example, in case of a mid-ureteric stone or a post-transplant case, patient should be kept in prone position. Imaging and targeting should be done in real time and frequently. Position should be checked after every 500 shocks, and it should be confirmed in both 0 degree and 30 degrees. These are the EO best clinical practices which are followed or recommended. We should ensure that there's correct use of coupling agent. Carefully fluoroscopic and ultrasound monitoring should be done. Proper analgesia should be given, and antibiotics should be administered whenever infected stones or bacteriuria are suspected. A word on role of pre-ESWL degestenting. It's usually done in large stone burdens because degestent secures drainage and prevents obstructive urosepsis. Used in renal insufficiency and when the stones are difficult to visualize. Though degestenting does not improve stone-free rates, nor does it lower the number of auxiliary treatment required. Complications are divided into immediate and delayed complications. Immediate being pain, hematuria, dysarrhythmias, renal and perirenal hematomas seen in 0.1 to 0.3% cases, surrounding organ injury, UTI, and obstructive uropathy. Delayed complications being impaired renal function, hypertension, stains transformation, and resident or recurrent calculi. Post ESWL, patient should be encouraged to maintain active ambulatory status to facilitate stone passage. Fluid intake should be encouraged. Most RCTs support medical and pulsal therapy following ESWL by the use of alpha blockers. PDI or percussion diuresis inversion therapy has significantly increased stone-free rates. Severe pain unresponsive to routine oral or IV medications should always alert about a perirenal hematoma, and further imaging studies should be done accordingly. A word on ESWL and pediatric patients. ESWL in children demands careful preparation in order to ensure an efficient therapy and to avoid collateral damage. Generally, stones are treated according to the same principles as for adults, but energy levels and number of shock waves applied need to be adjusted according to the age. It is crucial to be aware of the energy levels delivered by the system. If in doubt, always contact the manufacturer. An aluminum foil is placed below the thorax for lung protection. The foil is mounted at the deepest level of the lung during inspiration. For babies and infants of 1 to 5 years of age, fixation using elastic tapes may help to prevent movements. Always try to keep X-ray collimator narrow. In cases with proper focusing position of the stone and a lack of visible structure changes, energy levels must be increased, and we should always monitor for cutaneous hematomas, and if present, immediate reduction of energy levels should be done. In cases of proper fragmentation, energy levels should not be increased to prevent unnecessary fragment dislocation. When fragmentation proves to be efficient, therapy may be finalized prior to achieving maximum amount of shock waves, and there should not be any bilateral synchronous treatment. Moving on to the new advances, a visual track locking system. It used in ultrasound guided lithotripsy, uses an infrared handheld probe to triangulate the real-time stone location, achieves a stone-free rate of 80%. Burst wave lithotripsy, it uses 1:1 sinusoidal burst for over 0.5 microseconds. Low amplitude waves usually prevent excessive cavitation bubble formation, and they are highly efficient at stone combination at working phase. Struvite and uric acid stones combination is done in seconds, and calcium oxalate monohydrate stones can also be converted within 10 to 20 minutes. Ultrasonic propulsion uses handheld ultrasound device. High amplitude large pulse waves are used. Waves physically manipulate the stones in vivo. They can be used to relocate stones to more favorable areas of kidney. Can also relocate stones to leave obstructed systems. Used if skin to stone distance is less than 11 centimeters. HISTOTRIPSY focused pulse wave ultrasound used like burst wave lithotripsy, designed to fractionate tissue structures through extremely precise relocation, liquefaction, and can also be used in non-urological cases. Microbubble lithotripsy, it uses targeted microbubbles containing perfluorinated carbon gas with phospholipid centers. Bubbles have bisphosphonate binding domains to attach to stone surfaces. Bisphosphonates have affinity for hydroxyapatite. Using a 5 French urethral catheter, microbubbles are introduced in retrograde fashion. A 300 to 1000 kilohertz transducer is used, delivering 1.2 plus minus 0.2 megapixels pascals. 5 millimeter stones are broken in two pieces within a period of 30 minutes. This is a Dornier Compact Delta 2. We are lucky enough to have this state-of-the-art world's best-selling lithotripter, Dornier Compact Delta 2, in our very own department at SMS. This versatile and highly effective system provides flexibility necessary for easy positioning and accurate stone targeting, and has integrated Sanyam and ultrasound. Soon we'll be completing 50 cases in a very short period of time. With this, I conclude my presentation. Thank you.
Guidelines, same guidelines.
Sir, depending on the stone location, sir, if it is a non-lower pole stone, less than 1 centimeter stone, if they have a Hounsfield unit of less than 1000, and a skin to stone distance of less than 10 centimeters, ESWL is used. But they say that RARS or URS is equally effective as SWL. But it is between, earlier it was said that SWL is used, currently it is equal. You can use RARS or that also, ESWL also. In case of non-lower pole stones, we have to keep in mind the infundibule pelvic element angle, the infundibule length and the width. And again, it is said that both RARS and URS are equally effective. But in case of ureteric stones, RARS is preferred or the URS is preferred as compared to ESWL. Earlier it was said that ESWL is better, but in case of ureteric stones, it is typically that URS or RARS is preferred. Sir, in pediatric patients, the guidelines stay the same, but the energy levels delivered and the amount of shocks delivered have to be decreased, and that depend on the make of the lithotripter machine, sir.
Anything else? Pediatric. Have you finished your?
Yes, sir.
So, anything else which is important in pediatric?
Sir, we have to, sir, below the thorax, we have to keep enabling foil for lung protection.
Yeah. Most important is if you have to use for pain something, right?
Yes.
Secondly, the lung injury will be more in
Yes, sir.
pediatric. You have to use those styrofoam. Have you mentioned that?
Yes, sir.
Yes, styrofoam is very important. So,
aluminum foil mentioned here.
Yes,
As
sir.
I said, you have not mentioned
styrofoam.
Nobody is going to give you aluminum foil instead of aluminum foil. You have to easily available styrofoam. And even if styrofoam is not available, then simple बच्चों को lead in the and you just set about the lungs. But it's also important to be careful about gonads also. When you gonads को irradiation बार-बार लगता है ना, बच्चों में क्या है? Besides that, अगर आप lead apron एक lead apron ऊपर, एक lead apron नीचे, तो you can protect the gonads.
Lead apron से करोगे तो shock waves जाएगा.
नहीं वो window उसका बता रहा हूँ. Focus
lead apron पे window.
नहीं lead apron एक चेस्ट में लगा देते हैं और एक नीचे लगा देते हैं, इतना तो ओपन है.
Chest पर.
So
क्योंकि सर ये हमारे तो हमारे पेट में यही करते हैं. आप इतना abdomen को ओपन रखोगे. और चेस्ट पे एक लगा दोगे lead apron और एक gonads पे lead apron.
So what we are trying to have to prevent injury from shock waves and not the radiation. So I don't know. If it helps, then definitely. Radiation is again important. But for shock waves, whether the lead apron will help or not. Anyway, right.
What do you think about the role of the success of ESWL? Pediatric cases, is it better than adult cases, or in adult cases is it better, or is it PC?
And get बच्चे को देखो पहले बच्चे को और फिर इधर वो ले लेते हैं
Pediatrics में actually ESWL has got a very good role. Success rate is very high. This because क्या है कि crystallization जो होता है, it is a very loose crystallization. Adults में क्या होता है कि crystallization becomes very dense. But बच्चों में क्योंकि the process of stone formation has just started, the crystals are very loosely adhered. तो आपका ESWL से fragments मिलेंगे. बहुत अच्छा fragmentation.
Plus, not only the fragmentation, the passage of stone is also better in pediatric age. So lithotripsy is a good kind of option for pediatric stones if it is indicated. So anybody else? So the recent advances, what are the things basic? Don't show me that. Don't show me the videos. Just tell me.
So ballistic wave lithotripsy can be done. Which ballistic wave? Ballistic wave. Burst wave lithotripsy, sir. Burst wave lithotripsy. So it delivers a shock wave in the ratio of 1:1, and it has even shown that even the hard stones such as calcium oxalate monohydrate stones can be broken within a period of 10 to 20 minutes, and it has a special propensity for steroid and uric acid stones. So other than that, sir,
Just so burst wave lithotripsy, how does it? Because now we are doing a cavitation, right? That produces micro bubbles.
yes, sir.
So what happens that in cavitation, the micro bubbles remain there for some time, and so it prevents the further cavitation effect till the micro bubbles remain. So that is one of the drawback limitation of cavitation technology. And the burst wave technology is in that way superior to the cavitation technology. Right? What else?
So other than that, HISTOTRIPSY can be done, which is again focused, uses focused pulse phase like burst wave, and it also has uses other than urology, also such as in cardiac tissues in animals shown in animal models to create shunts. So microbubble therapy can be used, in which targeted microbubbles are used, but we have to use first a 5' ureteric catheter to inject the microbubbles retrograde, and then sir transducer delivers the shock waves. So other than that, ultrasonic propulsion can also be used, which is a handheld ultrasound device. These are the newer modalities.
So ultrasound is one of the very important thing which can like suppose the stone is an calyx, upper calyx, middle calyx, or lower calyx. With ultrasound waves, you can reposition it into the pelvis.
Yes.
So even for multiple stones, you can reposition the stones to a favorable position with ultrasound. So this is another kind of a development. And the other thing is doing a dual lithotripsy. There are now lithotripsys which have dual sources, right? So it's not just only one source which is focusing, there are dual sources. So dual source will produce more fragmentation, right? And the third is the fusion of sources. Now they have come up with EHL combined with ultrasound, EHL combined with electromagnetic. So both technologies can have their good effects and can produce better effects, right? So these are the advances which probably could help in better success rate, better results with the extracorporeal shock. So do you think that there's just the Hounsfield values which matter, or there are other stones which, even if I have lower Hounsfield values, are not fragmented with ESF?
So stones such as matrix stones, they are difficult to.
Matrix stones are very soft stone, but they will not be fragmented, or they will not come out with this. Why?
So because it is difficult to, because since they are soft stones, it's difficult to focus and make the shock wave exactly at that point. Because whenever you try to focus and the shock wave is delivered, it changes its position. So that is why. But when we deliver a shock wave, position change.
Interface.
Impedance.
And the other thing is that nowadays previously we used to think that narrowing down the focal zone would produce better fragmentation. Now the policy is to have a wider focal zone for better fragmentation. So
if you're not able to focus the stone, say, on a number of multiple factors like patient movement or the respiration, then how do you plan to achieve the lithotripsy also?
So we can give a patient general anesthesia, so that.
General anesthesia?
Yes, sir. So that.
Wouldn't that be an overkill? Like, how many patients you want to give general anesthesia? Is there anything else technically that you can do? You want to keep the patient at the focal point, like he's very anxious, respiratory, that would be. So is there anything that else can do? is there something which is known as a conical shock path? See there, ultimately, if you see the rays are coming in the form and they're coming on focus and they're taking a conical path. That is known as the conical shock path. So even if you keep the stone anywhere inside the shock path, the idea is keeping it at the focal point. But if the stone is moving and for a majority of the time it is coming in between the conical shock path, then also it will fragment well. Right? Because sometimes, change in the position, patient, pain ke wajah se it keeps on, moving. Just keep it inside that shock path. You might be able to result, you will get it.
So normally the newer technology has a gating technology where they would, with the respiration, they would even have a better kind of fragmentation. What is energy ramping?
So energy ramping is when
Just for energy ramping. So when you have a seminar, you should just at least go through the topic, right? So how many of you went through the topic before coming to the seminar? How many of them? None? फिर क्या मतलब है class? Progressively increase the right. So how does it help?
So energy, earlier it was thought that all the energy should be given at the stone surface in high maximum amount. But now they say that it should be started at a lower level, slowly increase. It helps because whenever we give shock waves or energy, there's vasoconstriction of renal in the kidney. So energy ramping, what it does is it gives time to the kidney to adapt to that vasoconstriction so that kidney damage is minimum. So
not only kidney, but the patient also. Suddenly, if you give large shock waves, then the patient will not be comfortable, right? And he will move also, his respiration will also change. So it's always better to do an energy ramping. Start with lesser shock waves and then increase the energy. Right. What is the usual energy that we get? What is the frequency? How many shock waves per minute? 15 to 20? पढ़ाई नहीं पढ़ा ये गलत. Next time यदि आप लोग नहीं पढ़ के आ सकते हो तो don't come to the class and give me an explanation. It hardly takes half an hour or 1 hour to just go through the chapter. इतना भी यदि आप लोगों के पास समय नहीं है तो फिर कोई फायदा नहीं है. और जब 8 बजे थे तो आप लोग केवल 8 जन थे, बाकी सब कहाँ थे? आठ बजे के बाद जो भी आया है वो उसे एक्सप्लेनेशन दे क्यों लेट. अभी भी सारे लोग नहीं आए, बस ये क्या अभी आने के बाद आगे थे सारे. चलो आना चाहिए.
I think the combination of the computer told about the stone path का बहुत अच्छा करता है.
बहुत अच्छा आपका. And all of you need to have a practical training also. So next time, you make a kind of a roster. These charts are local, so that whenever Kamlesh is doing ESWL, those who are relatively free, not in the busy in the OT, can go and see, right? इसका आप देखो कि हर 3-4 जो है लड़के जाएं.
As a matter of fact, Kamlesh को they should be asked to make a presentation and then you said you अपने पे inconsequential ये इनको लगता है कि हम inconsequential. It will increase his,
I appreciate your idea.
technicians they are just like doctors.
Yeah.
इसको अपनी self worth realize हो जाएगी that this is my self worth has not been given to this department.
I also propose, I just feel that we need to have a kind of a whole session on ESWL. We may call somebody who is really very proficient in ESWL, and एक बार उसको कंपनी वाले को भी बुला लेंगे, because ultrasound localization still we are not properly able to do. So we would like to have that training in ultrasound also. Okay, thank you very much. The sound was good. For the first time, the sound was good. How come